Hello, my name is Chris Marchak, and today I'd like to speak with you in regards to the use of cone beam CTs in treatment planning your patients for implants and using guided surgery to help with the restorative perspective so we can have success with our treatments and our patients. Because when patients present to you such as this patient referred for 2 implants in the central incisors. Traditional surgical template was created. Communication with the surgical colleague was used so that we have a defined treatment plan. What went wrong when the patient returns after implant placement, such as this? Where did the miscommunication between the surgical colleagues and the restorative colleagues come into play? Not using the surgical template? From the use of the diagnostic wax-up? How were we supposed to restore this patient based upon these implant positions, not where our diagnostic wax-ups were created? Or maybe it was this patient. The implants are too close. How are we supposed to manage interproximal tissues? Or the long axis of some of these restorations. Maybe it's 2 implants that were placed, but the patient continues to have pain. The question is, are these implants truly in the positions that you plan to place those implants? Did you think you have the implants in the locations where you thought they were placed? Maybe it's your best friend who had implants placed as a young adult. But what was the restorative treatment plan? And where are those implants placed? Because as the implants are positioned, is it where we need the support for the restorative prosthesis? This becomes a restorative nightmare and how we manage to treat these. In fact, when we asked our surgical colleagues why were the implants placed in these positions, truly the response is, well, it's where the bone is. Well, based upon traditional workflows, it is where the bone is. But we don't understand where the restorative components come in and how we can work together as a team in the restorative and surgical components so that we can look at new workflows and understand where our restorative prosthesis needs to be. Use 3-dimensional software and acquisitions from cone beam CTs so we can understand where we need to place those implants to have an ideal outcome. Because especially today, with new restorative materials, those implant positions have to be precise so that we can have the optimal prosthetic outcome. So when we look in comparison of 2-dimensional versus 3-dimensional imaging, 2-dimensional gives us inherent magnification. There's distortion. There's overlap of anatomy. And all of this may lead to more extensive surgical procedures that might not be necessary to have. 3-dimensional capture and 3-dimensional programs eliminates problems of all the 2 dimensions. And especially with these cone beam CTs, we have shown that we have low radiation in microsieverts compared to medical CTs. So when we look at these CT-guided surgical programs, what can we see? Well, there are many benefits, such as the ability to really understand and assess the quantity of the bone where we need to have that implant placed. Also, assess the quality of bone. How much cortical bone there is, how much cancellous bone there is, the density of the bone, the understanding of critical anatomical structures in 3 dimensions. Understand where all the anatomy is of adjacent roots, nerve, position of the teeth, so that we can also assess soft tissue with proper surgical or radiographic templates, and assess the planned restoration based upon where the bone, or vice versa, assess the bone where we want to have that implant placed and that restoration placed. And overall, evaluating that implant site based upon the planned restoration. So in these three-dimensional software programs, well, if we place the implants in, are we really getting them in the right place? If we make a comparison, well, what is more accurate? Is it the traditional surgical templates that have been performed or the newer surgical CAD/CAM templates? Well, Summit in 2003 looked at this in regards to accuracy in comparison between stereolithographic surgical templates and traditional workflows. He took 5 surgeons, looked at 5 epoxy mandibles. Half of the mandibles they scanned so that we can use traditional radiographic templates, and based upon the planning, drilled in the pilot holes of where we wanted those implants to be placed. So we converted traditional radiographic templates into the surgical templates using cone beam CTs. On the other side, we used 5 CAD/CAM surgical templates, and this was used with the SurgiGuide system, so that they were bone-borne templates. The implants were placed, and then the epoxy mandibles were rescanned. Now, when looking at comparison of data in any of these components, what is used is the comparison of where the planned implants are to where the actual implant is placed. What is usually measured is the distance between the center of the head of the implant to the actual implant placed, the center of the apex of the implant planned versus placed, and then taking the long axis of each one of those implants and looking at the angles formed. Those are the traditional 3 measurements of the planned versus placed implants. What did Summit find? Well, with traditional surgical templates and CAD/CAM surgical templates, at the head of the implant, traditional templates came out about 1.5 millimeters, plus or minus 0.7 millimeters, versus CAD/CAM templates 0.9 with a range of 0.5 millimeters. At the apex, 2.1 millimeters, and at the apex for CAD/CAM templates, 1 millimeter. The apex typically is further off because of the diversion that occurs. The apex is what's most off in all these studies. And looking at the degrees of diversion, 8 degrees versus in CAD/CAM templates, 4.5 degrees. Their outcome or their conclusion was that CAD/CAM surgical templates allow for improved implant placement. Well, Whitman did a review of computer-aided surgeries, and he determined, or he categorized the transfer of the implants planned versus the implants placed, called the IP transfer. That is the image of the software program and what is the physical transfer position onto the patient, the IP transfer. He states, based upon his review, it depends upon the accuracy of the registration of where the implant is placed to getting it to the patient, and the mapping between the 2 sets of data, the actual data of the capture of the CT and the physical space of the patient. The IP transfer can be done to the surgical site based upon 2 different techniques. One is called surface mapping. That is, you make a CT or cone beam CT of the patient, you capture that data, you then make an impression of the patient, and the cast is then scanned on a scanner, capturing that surface data and then transferring the 2 together, or merging those 2 together based upon enough surface points around the scan data of the cast and the patient based upon anatomical landmarks. The other technique is called fiducial related template. That is, using a radiographic template, placing radiographic markers in the template that are only used to superimpose the data. So therefore, the patient wears a radiographic template with these markers in place during the CAT scan. And then the radiographic template is then scanned a second time. And based upon those radiographic markers, those two images are superimposed based upon those fiducial markers. Well, understanding those two, Woodman came up with a few conclusions based upon CAD/CAM's surgical templates. And that is, if the templates were not stable and you did not have rigid fixations of the surgical template, errors will occur. And that makes sense because the surgical templates will move during surgery. As they move, are you getting it in the same position as was planned during implant placement and planning software? We also have a very precise mechanical fit is needed into the patient's mouth. It is of great importance because we want to make sure that template is properly seated. Again, proper seating of the surgical template to where we need to be able to have that IP transfer. So if you're using a fiducially related surgical template, we want to make sure that the radiographic template and the surgical template are in the same positions, that we have the proper mechanical fit of that template into the patient's mouth to transfer that position of the implant and from planning to the patient. Now, if the templates are made based upon a surface mapping, the most crucial aspect is the accuracy of that cast. Now, if that cast is not accurate, then, and therefore, the transfer between the two is very poor. So therefore, it is important and imperative to have accurate impressions if surface mapping is being used. Well, now that we understand about the two different types of templates, what are some of the studies clinically? Well, unfortunately, there are very few clinical studies. In fact, my knowledge is of only one clinical study, and that's by Di Giacomo, and this goes back to 2005. He looked at 4 patients. 21 implants were placed on these 4 patients. Radiographic templates were created for a CT scan using Implant software, and the surgery guides were created. 3 templates were fabricated per patient, which responded to the different sizes of the twist drills, such as the 2.2, 3.2, and 4.0 millimeter implants. These templates were both bone and tooth bone borne templates. So therefore, the templates were placed, the 2.2 millimeter drill was used, that was removed, then the 3.2, that was removed, then the 4.0 millimeter template was used, that was removed, then the templates were removed, and then the implants were placed without any guides, and a second CT was taken. What did he find? At the head of the implant, they were off 2.45 millimeters with a range of 0.2 to 4.5 millimeters. At the apex of the implant, they were off 2.9 millimeters, but a range of 0.8 to 7.1 millimeters. And the angular comparison between the two was off 7.25 degrees with a range of 3.6 to 12 degrees. Well, Daniel Van Steenberg and Mats Anderson did something a little different. They looked at having a template placed using fiducially related radiographic templates, having a template that is placed and stable. And now using the radiographic template, creating the surgical template versus a CAD/CAM, and placing and using guides to help with the osteotomy, and then most importantly, placement of the implant through the guide. In this clinical report, there was actually two different studies. One was on a cadaver, and the other was an immediate load study in this report. In the cadaver study, they looked at accuracy, and they looked at two cadaver specimens in the maxilla, where they placed 10 implants using these fiducially related surgical templates. They took pre and post-op CTs. What did they find at the head? 0.8 millimeters off. At the apex, 0.9 millimeters off. And an angular comparison of 1.8 degrees. Nell Van Ash and Daniel Van Steenberg went on to look at the use of cone beam CTs and the accuracy in partially edentulous patients. They wanted to understand and evaluate the precision of the transfer for these partially edentulous patients. They took 4 partially edentulous jaws. They took pre and post-op CTs using surgical planning software of Noble Guide, or at the time. And the CAD/CAM surgical templates were fabricated, and they used between 10 to 15 millimeter long implants. So again, the longer the implant, the greater the apical deviation can be. What did they find? An average angular deviation of 2 degrees, ranging from 0.7 to 4 degrees. At the hex, the mean linear deviation was 1.1 millimeters, with a range of 0.3 to 2.3 millimeters. And at the apex, 2 millimeters average, with a range of 0.7 to 2.4 millimeters. They concluded that cone beam images, cone beam CTs, could be used for very accurate implant placement, but we should always account what is the maximum degree of error that can be occurred as our safety zone. And in this situation, they looked at 2.4 millimeters in the linear deviation at the apex. So how do we look at this for patients in this technique? Well, first, we need to look at patients and do our traditional treatment planning in regards to where implants need to be and initial treatment planning for that patient. As we look at this, we can then make impressions to create a radiographic template. Using a diagnostic wax-up, we're planning for the extraction of tooth number 2 or the maxillary right second molar. A radiographic template is created covering the occlusal surfaces of the existing teeth, but not covering the surfaces of the planned restorations. An interocclusal record is made so we have stability of the surgical or the radiographic template at the time of the CAT scan, so we know and make sure that everything is properly seated. And between 6 to 8 fiducial markers are placed around the radiographic template so that that can be then scanned in a dual scan technique. So the patient is first scanned using about 0.4 to 0.5 millimeter cuts, and then the second scan is of the prosthesis only, or the radiographic template only. Again, a double scan technique is used, having one of the patient wearing the radiographic template and the other of the radiographic template alone. So the first scan is the patient is wearing the radiographic template and that interocclusal record that registers where the position of the radiographic template should be seated. The patient is scanned, and the information that we receive is the CT data of the anatomical positions of the patient, including the fiducial markers of the radiographic template. The second scan is only of the radiographic template only, without the interocclusal index. And what we achieve is to see the diagnostic wax up of the patient, where the planned restorative prosthesis should be, and also the radiographic markers, or those fiducial markers. Those two can then be superimposed to each other, so we can create from the radiographic guide, making a digital or three-dimensional template of the radiographic guide, so that we can then from there create a surgical template that is transferred. And we need to make sure that all those positions are exactly the same on the patient, so that we can then take these DICOM files into the patient. And these DICOM files are then inputted into a program such as this program that we're using here, which is Nobel Clinician, capturing the data from the cone beam CT, such as a Carestream, the 9300, and looking at this data. And as we input this data, we can manipulate the data from the three dimensions. We're looking at the coronal aspect on your upper left-hand corner, the sagittal aspect, and also the axial aspect. We can crop out data such as all the scatter that's there. We're planning this patient on the mandibular right-hand side so that we can crop out any metallic restorations that is caused from scatter. As we look and manipulate this data just of what we want to see, we can then be able to crop out the patient's spine, so this information, and then we can move into creating a three-dimensional model of the patient, of the mandible. Yes, we've cropped out the parts of the teeth, but actually the radiographic data is all there. So we have not lost any of the radiographic data such as roots and teeth, but it's just in the three-dimensional model that we've cropped out some of this. We can then take our next step of looking at the patient and the information, manipulating that, and looking at our radiographic guide and superimposing all that information together. So as we look at this, we can then create our radiographic guide capturing that data based upon those fiducial markers. We can also be able to calibrate this data to make sure that we have the exact size. We're cropping down any of the components of a stand, so we want to make sure that we have no metallic areas. Once we've completed this, we'll then convert that data into a three-dimensional model. Once we've captured this, we can see where our two tooth forms are, where we want to have from the diagnostic wax-up. We will then be able to superimpose the data based upon those fiducial markers, as we have seen here. Although that we have the cropped teeth, that information is still present in the radiographic data, and looking at the template and position of teeth that we want to see. We can also then take a look, based on this data, looking at three-dimensional positions of, for instance, the mandibular canal, and looking this from a panoramic view and a perpendicular slice. We can see where the mental foramen is, as we have it here. We're looking at the position of the teeth, and then start to mark the data as we annotate where the position of the nerve is. We like to first select the position of the superior border, and so what we're doing is looking for that mental foramen. Here we have the mental foramen, and then we can go ahead and move mesially to look at the anterior loop of the mental foramen of the mandibular canal. Making that mark, selecting that data again at the superior border of that mental canal, mandibular canal, and then going through back distally as we mark and we trace where the mandibular nerve is. We're also able to, based upon looking at the position, we can see where the tooth form is and where we want to have the next implant. We can select our implant, whatever type of implant that you would like to use, and also an abutment, so that we can decide whether we're going to use a Brandemark implant or a replace implant or other manufacturers that are now available in the Noble Clinician software, and be able to use different abutments. And if we look at the different abutments here, see the position, look at the long axis, make sure that we're not touching any adjacent roots, the anatomical structure such as the mandibular canal, and we're able to now move this to also in 3 dimensions. Based upon the positions of where those two teeth are, we can then create a surgical template 3-dimensionally and understand that that's what we need to look at. So once again, plan our implants, look at the long axis, look at where we need to be, make sure we have enough room, we can choose our abutments, choose our implants, and then look at the locations of the implants prior to implant placement and evaluate this and creating our surgical template, all in 3 dimensions. Truly, we've just done implant surgery the first time around. Now we're going to do an implant surgery on the patient itself. We can look at this in the panoramic view and its different surgical contents, and then also look at the actual surgical template before it's produced, and have understandings of the ability to actually truly produce this template without any hesitation from the manufacturer's standpoint. Once we get back the surgical template, we can actually place it into the patient's mouth using an index to make sure that we've secured the position of the radiograph of the surgical template in the same position as the radiographic template that was during the cone beam CT images and capture that data. A anchor pin is placed so that we can fixate the surgical template, because remember, we do not want to remove the surgical template. Once the surgical template is placed, we do not want to remove it, keeping it in the same position and then going through the different protocols of implant placement, starting with our 2mm twist and using then a 3mm twist to place the next osteotomy. We're going to place in a 4.0mm diameter implant. As we place here, after the 3mm twist is used, then implant placement is completed using an implant mount, and having that implant mount stop exactly at the coronal portion of the surgical template to ensure accuracy of where we want that implant to be placed. This is the 3-month post-op of the implants. This is the provisional restoration that was created. The abutments that we had used some snappy abutments here, and making the impressions to create the crowns. Here we have 2 zirconia restorations that were cemented and the restorations at placement. This is the radiographic data before, the radiographic at the time of surgery, and the radiograph of the restorations in place and seated. So therefore, when we look at this, there are many advantages of cone beam CTs with guided surgery. Precision for the anatomical landmarks, and that's because we have a better understanding of patients' anatomy because of the 3-dimensional imaging. The 3-dimensional imaging, the clear images that we achieve with the cone beam CT such as 9300 allows us for safety of implant placement based upon those anatomical landmarks, so that we can avoid crucial anatomy for safer implant placement. And it also allows us for understanding of the quality and the quantity of bone. Understanding the quantity of bone around the implant, so we know how much bone is actually around the implant. There have been studies in regards to stability of bone around an implant, and one of the issues is understanding the quantity of bone to have that stability, and at least we know precisely how much bone is around it. When we do it freehand or at the time of surgery, do we really understand what is happening in 3 dimensions, how much bone there is? And with the capture of cone beam CTs, it allows us to understand this so that we can also possibly place implants in, maybe without grafts. We understand where the implants are, where the restorative prosthesis needs to be. Do we need to have grafts in some of these patients? Maybe, maybe not. We have the precision of implant placement, and that's because we understand the accuracy needed due to anatomical restrictions. We have the ability to place in implants precisely due to restorative limitations, and we have the precision for restorative procedures. That is, understanding multiple implants and having the need to have the accuracy placement for better aesthetics and predictability for these patients. But there's always limitations, and limitations to guided surgery. Some may say longer treatment times. Especially with this system, we have multiple appointments based upon the fabrication of a radiographic template even before cone beam data can be acquired. We need to make the impressions, create a diagnostic wax-up, then a radiographic template, plan it before we even have the surgical template. Some may say also there's more radiation based upon two-dimensional studies, but we now know with current cone beam CTs that radiation in microsieverts is much lower than medical CTs, and even the same, if not lower, than some panoramic data that we can achieve, as well as full mouth series. In some of the navigation systems, we have very bulky instrumentation, and even with traditional CAD/CAM guided surgery, we could have this longer instrumentation, which makes it difficult for posterior implant placement. But with the understanding of the surgical instrumentation, we can overcome all of these limitations in regards to implant placement in the posterior segments. As well as cooling. Cooling of the osteotomy because of the restriction of the surgical template. We really need to understand cooling well, and maybe we can percolate the drills and be able to cool the area very well during the osteotomy preparation. And there's cost. Cost to the patient, cost to the dentist in regards to setup, cost of the programs, and also cost of the surgical templates. But in patients such as this, maybe it really is important for us to achieve this result. Taking patients such as what we have here, who's not happy with his fixed dental prosthesis, a 3-unit bridge from the canine to the central incisor to the canine. Patient actually had orthodontics completed to try to place implants in where the patient had congenitally missing lateral incisors. Because of the anatomical restrictions, we decided to do this in a guided approach as we created the space, made our provisional restorations, and from these provisional restorations duplicated into a radiographic template, so that from this radiographic template we can have the patient go back for a CT scan and understand where we need to create and place these implants. Now looking at from a 3-dimensional standpoint in the lateral positions and understanding the restrictions we have based upon the thickness in the buccolingual dimensions, as well as the restrictions to the adjacent roots of the canines and the central incisors. But we're able to place these implants in precisely, eliminating the contact of the adjacent teeth, once the implants were placed, traditional healing was used and custom abutments were used for the implants with the restorative prostheses or crowns cemented to place, taking the patient before and after. Or maybe it's this patient who's been wearing a removable prosthesis for many years and looking at the radiographic data to understand that we would consider placement of implants in the edentulous sites. There are many different options, and as we look at these different options, our patient decided to keep the remaining teeth based upon the lack or the stability of those teeth periodontally in the restorations, and therefore we decided to do a diagnostic wax up and understanding where the positions of these teeth are in the ideal positions. Here's our diagnostic wax up on the patient, understanding tooth positions of where we want to have the implants placed, and scanning that data into our software. Using a three-dimensional scans, here's our radiographic template and the proposed implant positions, understanding how much space we need per implant, and in the three-dimensional realm, understanding where we're going to place those implants. Traditional implant healing was used in a two-step approach. After the second stage surgery, we then converted a provisional restoration or fabricated a provisional restoration so we can start the healing process of the soft tissues. With this type of prosthesis, accurate implant placement is crucial so we can understand where the prosthesis is and based upon that with the implant placement. Here is the provisional restoration as we look for healing and the restorative procedure of duplicating that position in an index and duplicating the provisional restoration in resin so that we can then look at that in the patient's mouth, confirm the fit of this prosthesis, and then duplicating it in a zirconia restoration, milling it out in zirconia and truly understanding the accuracy that is necessary with our prosthesis in place and the zirconia prosthesis, and looking at the screw access holes that we need to have in support of this prosthesis in the lateral positions and in the position, the occlusal and frontal, taking the patient from before to after. Well, as we look at all of this, I have a few suggestions, especially for guided surgery and CAD/CAM templates. We want to understand those studies and look at how much we need to allow for error. Because of these systems of transfer, are you as accurate as possible? We need to understand the three-dimensional aspect and allow for those possibilities of error, especially at the apical dimensions. If you're using other systems, make sure that you have what we call inspection windows. You want to make sure that the surgical template is properly fitting in the position that the radiographic template was seated or the planned position in the software. Always try in your surgical templates before surgery so that we know that you have proper positioning of the template. The template needs positioned correctly for the proper image to patient transfer. You can also use these templates to use flap surgery. You don't have to have flap bliss surgery. You can do this in traditional means, but you need to make sure that you allow for the space and have proper rigid fixation. And if you do surface mapping templates, make sure that you have very, very accurate impressions so that that transfer can be made correctly. There are also many benefits of guided surgery, and the benefits include shorter treatment times. And I believe it's really because of more accurate pre-planning, and that's truly because of the 3D planning software and the use of cone beam CTs. This information is so important in regards to our treatment planning, especially from a restorative standpoint. So we understand where the prosthesis needs to be and the position of the implants can be placed. We have shorter surgical times, and that's because of the accurate surgical instrumentation that's been created. Maybe it's because of flapless surgery, so faster healing, and it truly goes back to the more precise 3D planning with the use of cone beam CTs. We have less invasive flapless surgery possibility, and that's because of the 3D planning. We understand all the patient's anatomy with those cone beam CTs. Therefore, patients have less pain, less discomfort, and maybe more patients are willing to do and accept implant surgery. If we wanted to, we can also create the prosthesis prior to implant placement. We can create a definitive prosthesis if we wanted to, or more importantly, just do it for the accuracy of implant with traditional loading. We have the accuracy of implant placement, and that's because we're really doing the surgery twice, once on the computer and once on the patient. But we have the ability to make a better diagnosis, understand the patient's anatomy with more understanding because of these three-dimensional acquisitions from cone beam CTs and three-dimensional software programs. We have now over 8 years of follow-up studies with this technique, with the CAD/CAM templates and the surgical templates, and with the surgical instrumentation. And with that, I thank you for spending the time with me and looking at what we need to have in regards with implant placement with a surgical template and the three-dimensional imaging that has been acquired through cone beam CTs. Thank you.